Morning, morning, everybody. Hope you're well. Let me just sort this out. Morning, Martin. Hope you're doing all right, mate. Let's just get that going across the bottom so we know what episode it is. Yeah, welcome back. We are finishing off the nerves today. Hopefully, if we get through everything. So nerves and blood supply for the hip and pelvis. This is the second installation. Uh, Morning, Tris. Well done on your deadlift. Is it 200 kilos you got? It's nice. That's pretty heavy, that. Yeah, really good. Okay, let's get going here. So I gave you a little bit of homework. Let me just adjust my seat slightly. There we go. Gave you a little bit of homework to have a look at this. The lateral cutaneous nerve of the thigh. Obviously, everybody rushed away and did it straight away because nobody put anything in the group. So, why did I mention this one in particular? It's because it's something that's quite common, and we've talked about different nerves over the last few weeks and the different types of nerve as well. So we had the articular branches, the sensory branches, and the motor branches of nerves. So the motor going to the muscles, the sensory from the skin, or cutaneous nerve from the skin, and then the articular branches from the joints, so from the capsule and the joint surfaces. And this particular nerve, the lateral cutaneous nerve, is a cutaneous nerve, so it's a skin nerve, and it's lateral, so it's on the outside of the thigh. Okay, and so if you lose sensation on the outside of your thigh, let's get my arrow. There it is. Here, just around there. Then sometimes people may think that there's a problem with the any kind of neurological symptoms. Most people say, "Oh, I've got sciatica." Yeah, if they've been diagnosed with that, then they need to go and see something else. If they've got symptoms here, then sometimes it's linked into the femoral nerve. But as we looked over the last, I think it was last week or maybe the week before, these are the sensory branches of the femoral nerve. So this is the anterior femoral cutaneous nerve. So it's a branch off of the femoral, and it supplies the front of your thigh. So it's different. It's a different kind of area. There is overlap, yeah. So there will be some overlap, but it's this bit here that's really interesting. Um, Too late now, Martin. No, good on you. Yeah, squirrel away. Have a look for lateral cutaneous nerve and then symptoms, and it will come up with a particular condition, which we'll have a look at now. So so this particular nerve here, it its only job is sensation on the outside of the thigh. Yeah, so that's the front of a right thigh there. There's the back of a left one. So it kind of comes around the back a little bit as well. Comes from L2 to L3. So lumbar vertebra 2 and 3. And yes, well done. Very good. So it's very common with compression shorts. People who wear like utility belts for work, so like plumbers or carpenters or something like that, where they've got a belt on, police officers, and they've got quite a lot of stuff hanging on the belt, and it's because of where the belt lies, and it is this particular area up here. So see where the nerve comes through there. That's a compression point there. Other people who get this as well, people who drive a lot, so taxi drivers and long lorry drivers, that kind of thing. So because of the position you're in hip flexion, especially if you're carrying a bit of weight as well, then it will compress that nerve and it will make the outside of your thigh go numb. It's usually horrible to lie on, so you lie on that side at night, and then that gives you your symptoms as well. So any kind of compression, but then equally, lying on the other side can, and if your leg is adducted, then it will stretch the nerve as well, which can irritate it. So quite often it's relieved with putting like a pillow in between the knees when you're asleep. So the oh, I thought there was another slide there. So the name of the condition is this: neuralgia paresthetica. And basically, it's compression of that particular nerve. I don't think we've got. Let me just have a look. No, there's no. See, the thing is, it's really difficult on dissection to see these nerves because they're so small and they're in the skin and well, there may be some new videos that have come out that show the cutaneous nerves a little bit better because we're starting to realize the importance of those now. But previously they just weren't important. That's why we don't tend to find videos on them. If you Google it, I'm sure you'll find some images of the lateral cutaneous nerve and where it comes through. So it's under the inguinal ligament. Okay, and it's right by the ASIS, so it's right in that spot there. So yeah, if someone's wearing a belt, yeah, driving job, that kind of thing, they've got lateral numbness to the thigh. It could be this, and it could be that that's causing it. Okay, so yeah, that was linked to that. Cool. And then I've got this. So the reason why I've got this down, thinking why have we got the quadrants of the abdomen? It's useful for the next bit when we move up the body, because it splits the abdomen into regions, and but it's also useful for the cutaneous nerves around the pelvis as well. So the skin nerves around the pelvis and the hip. So if I just show you this a second, just get rid of that. So we've got different regions split into 9. So we've got this area here, which is your iliac region. This one here, hypogastric. Okay, so just there. Left iliac, umbilical or umbilical region, however you want to pronounce it. Right lumbar, left lumbar, and then this one up here, right hypochondriac, epigastric, and then left hypochondriac. Okay, so those are the regions of the abdomen. And if you're doing like osteopathy, or you're doing physio or chiropractic, something like that, where you will have to learn these regions. And certainly in osteopathy, we would have to understand the examination of these regions and what structures are in each zone. Okay, so yeah, that may be useful for some of you depending on what you're studying. So the reason why I've put that there is because of not this one, but the ones in a sec, because some of the nerves that we're going to look at are called iliohypogastric. So if you know these and you know the regions of the abdomen, then it makes those names make sense, because you're like, oh, okay, cool. So it's coming from that area into that area, and it should hopefully help you a little bit. So this one, just want to cover this. So this is another skin nerve. This is the perforating cutaneous nerve, and it is. Let me just show you here. It is from S2 and S3. So I've got a little image here from Complete Anatomy. So if you're looking for a software that is really good for anatomy, then Complete Anatomy is amazing. And I've been able to isolate this nerve there. So you can see it comes out of the front of the sacrum and then drops down the pelvic floor, and gives sensory distribution to the middle and inferior buttock. So if we have a look on the picture here, the perforated cutaneous nerve is that bit there. Okay, so it's right on the crease of your butt cheek, right where your ischial tuberosity is. So again, any loss of sensation there is well, again, there's crossover between the different regions again. But yeah, loss of sensation around that area is not coming from the sciatic nerve, and we said that last week. So the sciatic nerve has sensory input in the leg, but not in the thigh. So around the buttock, around the back of the thigh, are nerves that are separate to the sciatic nerve. Okay, so yeah, perforated cutaneous nerve is that little bit, that kind of patch there. Okay, so if you have any loss of sensation, S2, S3, around that area just there. Okay, right now, These are are some interesting ones. I talked a little bit about this on a post I did the other day. So there, you've got the gluteal nerves, which we'll be able to see a video of because they are motor nerves. So they're like important nerves. So that there's dissections of those. But then we've also got skin nerves around the gluteal region as well. Okay, so going to have a look at the motor nerves first, and then come out a little bit into the skin nerves. So the gluteal nerves, we've got two main nerves. So we've got superior gluteal nerve, and if you remember from when we were doing the bony anatomy of the pelvis, this is the greater sciatic notch, and it loops around there. Okay, so it comes from the front of the pelvis or inside the pelvis, and then out through the greater sciatic notch. And this superior gluteal nerve comes from L4, L5, S1. Okay, so it's very similar origin to the sciatic nerve, so it shares nerve roots. And we've got motor function for the glute medius, glute minimus, and tensor fasciae lata. Okay, so the motor for glute med, glute min, and TFL. All right, so and you can see that with the area that it supplies. So that's your superior gluteal nerve, and then the inferior gluteal nerve, same or very similar origin again, L5, S1, S2, but this one supplies just glute max. Okay, and you can see the trajectory of this one; it kind of goes upwards rather than round to the front. So let's have a look at those. I'm pretty sure, yeah, we have. Cool, let's just get rid of that one, pop that one on. Okay, so these are the glute nerves. So these are the motor ones. These are the ones that turn on the muscles. And we'll have a look at the sensory ones in a sec. Okay, so this should be a familiar view over the last couple of weeks. So we had the femoral nerve coming this way. Okay, so that was supplying the front of the thigh. Then we've got the obturator nerve going through there. So there's that little gap with the obturator foramen. Okay. Who was I reading the other day? A guy called Tom Jesson. He does some really good stuff. Jesson on disc problems and nerve problems. Explains it really, really simply, really, really nicely. And he's got in my head instead of foramen, foramen, and then changed it into George Foreman. And if you like boxing, that is just a nightmare because I can't stop thinking about that name now, and I'd never ever thought of it like that before. So yeah, maybe that's a good way to remember it. The George Foreman. So we've got the obturator foramen, where the obturator nerve will go through, and then these nerves here, these made up the sciatic nerve, which we looked at last week. Okay. Now we know that the gluteal nerves, from looking at the past couple of slides, they share a nerve root with the sciatic nerve. So it's going to be very, very close to there. So let's have a look where they emerge from. Here we go. So there's L4, L5, S1, S2, S3. Okay, so those are the nerve roots. Piriformis back there. So that's your sciatic nerve, L4 to S3. We were looking at that previously. And now there's your gluteal nerve. Okay, so that's your superior gluteal nerve just there. And I think, yeah, we should be able to get a view through the other side as it pokes through. So that's the greater sciatic notch. So round the back, so there's your glute max. And then here's your piriformis. And there'll be a little nerve coming through around here, which will be your gluteal nerve. So sciatic nerve is the big one. And then there we go. So there's your inferior gluteal nerve just there. And then there's the superior. Okay. So that's off. Superior is going off to glute medius. Here we go. So glute medius, glute minimus, and then TFL. So that was on the previous slide. And then the inferior nerve supplies your glute maximus. Okay, so it's tiny, but the glute maximus innervation it only does that's all it does. So literally to that muscle, and that's it done. Okay, so those are the motor nerves for the glutes. So they're not coming off a branch off of the sciatic. They share a nerve root with the sciatic, but they've got their own specific branches. Okay, so superior and inferior gluteal nerves. And then these are the ones that are the skin nerves, and they're around the genitalia and around the femoral area, so the front of the thigh. And these are really interesting because if we have a look at some of these pictures, these are some classic pain patterns that you might see, and can be confused with other things. So people go away for scans, and then if they come back negative, that's great, but it's also frustrating because it's come back negative. And the problem is you can't see an entrapment of a cutaneous nerve on imaging. But if you know where the nerves go, and all the scans have been clear and everything else has been cleared up, then you should then have a look at these and the pathway of these. So if we have a look, if I just move me out of here. So we've got two branches, the genital branch and the femoral branch. It comes from L1, L2. And if you're male, there's a motor branch which goes to a muscle called the cremaster muscle, and that elevates the testicle. Okay, so yeah, it's obviously only found in males, that one. And then sensory branches are male and female into the upper thigh. So there we go. So there's the genital branch of the genital femoral nerve, and it will go into so the labia or the anterior part of the scrotum, and that can be confused, especially in males, as a herniation. So if someone's coming in complaining of groin symptoms, and it could be a hernia. I mean, obviously you need to get that checked out, need a scan, but it could be an irritation to the sensory nerve, the genital femoral nerve, and that then is similar to the lateral cutaneous. Yeah, so if you compress it or it gets irritated, then it will make the lateral cutaneous nerve will make the outside of your leg feel numb. If this one gets irritated, it will make your bits feel numb. Okay, so that's something to consider, and here as well. So that area just there. So we've got genital femoral nerve splitting into femoral portion, and then the genital portion just there. Okay, so again, things to add in to your differential diagnosis or whatever you want to call it, if you've got somebody who's got loss of sensation in those areas or strain sensation. So you've got the cremaster muscle that will lift the testicle. So yeah, that's that one from what you call it, Netta, I think that is. And then this is the reason why I showed you that picture of the quadrants of the abdomen, because we've got ilio hypogastric. So we've got a nerve that travels from the ilium region through to the hypogastric region, which is the front lower portion of the abdomen. So let's have a look at this. These are sensory nerves coming from L1, and they provide sensation to the skin above the waistband. Okay, so we've got well, you've got a few. So you've got iliohypogastric just here. Okay, so just above that kind of inguinal ligament line, and then the ilioinguinal or ilioinguinal nerve, literally just on that belt line. Okay, this one we've already had a look at. So that's the lateral femoral cutaneous. That's where that meralgia paresthetica comes from. Anterior femoral cutaneous, which is the skin on the front of the thigh, and then the genital femoral nerve, which we looked at, the femoral branch of it just there. Okay, and then the genital branch coming down here. So all of those nerves, they're all supplying the skin around the kind of front of the pelvis. Okay, there may be a problem at the nerve root, so at L1, okay, which is affecting this particular nerve, or it could be anywhere along its pathway. Okay, and this is where learning about without kind of selling the course, but learning about dermoneuromodulation. And if you've not heard of that, then have a look for a lady called Diane Jacobs. And she's written a really good book, and she's done loads of good videos as well. And she talks about the pain, if you like, or the weird sensation from compression of the cutaneous nerves. So, and these are some of the really key ones around this area. We don't really tend to learn about them, to be honest. I certainly didn't cover these when I studied osteopathy. It's something that I've learned afterwards. You may do in some schools, but I certainly didn't in mine. So ilioinguinal. So we've got the ilium region, and then the inguinal or inguinal region. So it's coming from L1 again, along the inguinal ligament and the inguinal canal towards the genitals, and then runs underneath the iliohypogastric nerve. It's sensory and provides sensation to the anterior part of the scrotum and the labia. Okay, so again, we've got another nerve. So around this area here, just move me out of the way. Ilioinguinal nerve around there. Okay, and again, there's going to be crossover between some of these, yeah, it's again something else to think about. But if you have a look here, look at where it runs, like literally follows the inguinal ligament and wraps around the iliac crest. And this can be a really, really sensitive area for some people. Okay, so it may be a sensation from the cutaneous nerve. Again, something to think about. Good, yeah. There's theories, manual therapy, but very, very light, and the kind of, it's really weird because there's no kind of black and white with it. And we don't really know whether it's having the effects that we do. We just know the outcomes of what's happening. And it's similar to kind of myofascial release type stuff, where it's very, very light pressure for a fairly long period of time. And you just go in whichever direction that somebody feels reduction in symptoms. So we do this quite a lot with, it's literally just dragging the skin. So if someone has a weird sensation around this area, and they've had everything checked out, you could just put your hand on the skin and drag it back towards the ASIS or the spine, and kind of move it around and see whether offloading the nerve helps to reduce the symptoms. And sometimes it does straight away, and it's like, and somebody's been in pain for ages, and they're like, is that it? That, that has solved my problem. It's likely to come back. It may come back again. So something that you can do. Again, I don't think you can study this kind of stuff. It's just kind of anecdotal type stories. You can use tape to hold the skin in position of ease. Okay, so you find which direction it works best, put the tape on to keep the skin in that position as long as it doesn't irritate anything, and that may then give the nerve the chance to calm down, because it's irritated for some reason. So there may be some kind of inflammatory process, and that kind of offloading may give chance for things to settle down. That's the kind of theories. Okay, so yep, manual therapy, taping, but because of the variation and the crossover, it's all very much working with the patient and working out which direction feels good. And yeah, sometimes this can be miraculous, because especially the myalgia paresthetica, people are really irritated by it, and then you literally just lift the skin or pull it back, and then it eases the symptoms, and they're like, what the hell have you just done? It's sometimes as easy as that. Cool. So we've then got the cluneal nerves, and these are the nerves that supply the skin over the glutes. Let's just have a look at these. So these are arising from L1 to L3. We've got sensory, so the superior cluneal nerves. We've got three of them all together. Three of them, maybe four. I think three big ones. So sensory, top of the buttocks. Oh, here we go. Three branches: medial, intermediate, lateral. Okay. So they supply the skin over the buttock region. And again, another common area for you to have like loss of sensation or weird sensation around that region. And again, quite often you get kind of stuck in, especially if you do manual therapy, to get into the deeper structures. And if actually it may be that the the skin needs attention rather than trying to push through with deep pressure. Okay, so yeah, this region here, the superior clineal region supplies the top of the buttocks, and then we've got the middle clineal, which comes out of the sacral area, so S1 to S3. This is skin over the glute max. Okay, so that's over the main butt cheek. Okay, and then we've got the inferior clineal, which is the skin over the inferior buttock, and that will be close as well to the perforating cutaneous nerve that we looked at previously. Okay, so these are all skin nerves that receive information from the skin. So if there's any kind of irritation in there, then the skin will feel weird. Okay, and everybody experiences different symptoms. Yeah, these are the cluneal nerves. So gluteal and cluneal mixed together. So superior here, middle here, and then inferior here. So it's all over that buttock region. And if we go back, yeah, so that's a nice image there actually. So you can see them coming through and perforating the skin just there. So if we have a look back, so yeah, we've got S1 to S3, and then L1, L2, L3. So there's quite a wide spread of the nerve roots for these particular sensory nerves, and they will go into a specific part of the spinal cord. So there's a sensory receiving area in the spinal cord, and we'll cover that when we get to the spine. And as you've seen, it doesn't just receive information from one nerve. So L1 to L3 won't just be this nerve, the superior clineal. There's various other nerves that will enter into that sensory region as well. Okay, and this is where we think that referred pain comes from, because if you press on the glutes, so around this region here, sometimes you can get pain down your leg and into your foot, but that is in no way connected to down into your foot, unless you're pressing on the sciatic nerve, which is down here. But if it's up around this region here, you're nowhere near the sciatic nerve. So the theory is that the information that's coming from these nerves goes into that part of the nerve root. And because it's shared information from somewhere else as well, the brain then makes the decision that sensation must be coming from this one, which is the one that supplies the leg. And that's why you feel the symptoms in the leg. So it's similar, but obviously not as drastic as a heart attack. So you feel a heart attack or heart attack symptoms down your arm, but there's nothing wrong with your arm, but that's where you feel the symptoms. And it's because the nerves that supply the pericardium around the heart, they come from around the neck, and because they're shared with the arm, the brain thinks it's coming from your arm and not your heart. Okay, so that's why those symptoms occur there. So I use that with you guys because we're talking about anatomy, but I wouldn't use that analogy with patients, because it might scare the bejesus out of them talking about heart attacks and referred pain. They'll think that something's really wrong. But those are the theories why we think that's happening. And we've talked about it before as well with Kerr's sign, where you've got irritation of the diaphragm, maybe from a liver problem, and that refers to your shoulder. Okay, and it's nothing, there's no problem with your shoulder, there's no issue there at all. It's coming from the liver, but it's irritated the diaphragm, and the diaphragm nerve innervation comes from your neck, which is shared with your shoulder. So that's where you get symptoms there. Okay, so pain somewhere is really difficult to pin down, okay, because there's so many different things that it could possibly be. Okay, cool, right. That's your cluneal nerves, right? And then we've got your pudendal nerve, and we're going to have a look at this region in a bit more detail. We're going to have a look at the pelvic floor next, I think we've got there's a break coming up next week because of the bank holiday, but then the week after we're going to have a look at the pelvic region. So your pudendal nerve, S2, S3, S4, you might have heard of this one. This one's a classic for cyclists. And basically, if you're riding a bike and it's got a pretty hard saddle, then and it doesn't have one of those holes in the saddle, then you can compress the pudendal nerve because it's right near your sit bones. Yeah, so right near there. And what it does is it supplies the perineum, so the bit in between the anus and your genitals. So that area, if you compress it, will just go numb. Yeah, and again, that's quite a common uh, problem that cyclists will come in with. Yeah, they'll say that especially with blokes, their nuts will just go numb. Okay, and you may not have realised it, but that's what can happen. Okay, so what the pudendal nerve does in terms of motor is DMC. So it's defecation, so pooing, micturition, and copulation. Okay, so pooing, weeing, and sex. That's what the pudendal nerve does. Okay, so it's not the run bit; it's just the DMC bit. So that's your pudendal nerve. There you go. So defecation, micturition, and copulation. So going for number 2, going for number 1, and having sex. And these are the different types of entrapments. So where the pudendal nerve arises from, you can get a problem coming out of the sciatic notch, between the ischial spine and the sacrosciatic ligament, the obturator internus muscle, the obturator internus and piriformis, or the distal branch of the pudendal nerve, which is usually the compression site. So if you've got some kind of major tension around this area here, then that can compress the pudendal nerve, and then it will give you odd sensations into your bits, basically. What I do if I get someone who's got these kind of symptoms come in, we get them to change their seat if they are a cyclist and get one of the ones with a hole in. Otherwise, we'll get them to see a pelvic health specialist. And what they do is they specialize in internal massage. And I don't do any of that. I'll refer them out for that. They work on these muscles. So obturator internus can work on the piriformis and the pelvic floor muscles. And they do it internally with manual therapy. Okay, so if you didn't know it's out there, and there are some specialists in the UK. We've got one literally just down the road from us, a guy called Gerard Green. So if you've got someone like that, then there is hope for them. They can get that kind of help. Cool. That's all your nerves. Okay, so let's have a look at this. So now we're going to have a look at the blood supply around this region. Bear with me a second. I'll just grab the PowerPoint. Blood supply. Here we go. Oh, wrong one. Sorry, bear with me a second. Just pop the blood supply onto there. Okay. Hopefully that's it. Yeah, here we go. Right. So only a couple of slides. What time are we at? Yeah, perfect. We've got plenty of time. So we'll be able to finish off the blood supply as well today. That'd be good. So what have we seen already? At the knee, we've seen where the femoral artery turns into the popliteal artery. Okay, and it's exactly the same artery. It's just given a different name at the different points that it come through. And then, but this is where it's originally come from. So this is your descending aorta, obviously because it's red. And then this is your inferior vena cava. So this is the main deoxygenated blood back to the heart. Okay, we've got some branches there going off to the kidneys, but this is the area that we're interested in because we're going to have a look at the pelvis. So we've got descending aorta, which is this one. So that's that there. That's coming directly from the left ventricle of the heart. Yeah, so it's one of the first areas of blood supply that we get, newly oxygenated blood. Then we've got the common iliac arteries, which are these ones here. Okay, so this level here, this is around the level of L3, L4. So it's about your belly button. So around the level of your belly button, that is where it splits. Okay, and it divides into your iliac arteries, and they go one down the right leg, one down the left leg. So it starts off as one descending aorta and then splits off into your iliac arteries. Then we've got another split. We've got external iliac and internal iliac. So if we have a look here, there's the other split just there. Okay, so external iliac coming this way, internal iliac going that way. Okay, right. I think hopefully we've got some. Yeah, it'd be this one. I think. Let's have a look at that. So femoral artery near the hip. Okay. Oh yeah, that's a good one. Okay, so let me just pause that there. So there's your descending aorta just there. And obviously in real life they're not red and blue, just like in the books. So that aorta there splits here. Okay, it's quite low on this one. And again, there's variability for all of these. And then this is your iliac arteries here. Okay, so that's your iliac artery. And then see there, it splits again. Yeah, so that's where it changes into external and internal iliac. So this will be the external one. And look where it goes underneath the inguinal ligament. So that there, once it passes under there, is now the femoral artery, which is the one we saw before. And then as it goes down towards the knee and then goes behind the knee, that's then the popliteal artery. So again, it's all the same. It's just given a different name as it goes through. So descending aorta splits into iliac arteries, and then we've got external and internal. So that the internal one is going to supply all the pelvic floor and I kind of around that region there. Right, let's have a look where it goes. Hopefully, there we go. Okay, so you got your common iliac arteries, so right and left. So those are your, on the last slide, iliac, and then external iliac and internal iliac just there. Okay, and then down here, there's the inguinal ligament. There's your pubic bone, and then there is your femoral artery, just there. Okay, so that's how they all link up. And then look at the little branches. Yeah, so we've got a split in the femoral artery. There's the pudendal artery that goes off to supply the perineum and the genitals. This one supplies the skin. And then look, there's this one down here as well. Okay, that's your deep femoral artery. Yeah, so this one will carry on down towards the knee. This one will go deep towards the hip joint. So sartorius just there. And then there it goes down there. Okay, so that's where we left it when we were looking at the knee. Okay, now if we have a look at the deep femoral, so this is the branch that comes off of that one we've just seen. Just checking time. Excuse me. Okay, so there's the deep femoral. So there's the femoral that we saw before. So we're going to take some of these structures away so we can have a look at that one. So sartorius just there. And there we go. Okay, so this is the deep femoral. So this is supplying, well, all these muscles, and it goes towards the neck of the femur. Let me just pause that there. Let's go back one. There we go. There we go. Cool. So see these ones here, that little branch there and that one there. These are called circumflex. So basically they make a circle, and they make a circle around the femoral head. So they're going towards the hip joint, okay, and supplying that region around there. So this one supplies the adductors, the obturator externus, gracilis, hamstring, sciatic nerve, and the head and the neck of the femur. Okay, it's that deep one that supplies all of that region, and then and sometimes this is called the profundus, because it's deep, it's profound. Okay, and then this one, the lateral circumflex, sartorius, and all of the lateral structures. And there we go again. Look at that as it snakes through. So all of the adductors there. You can see as it's going in and just supplying those muscles. Okay, so really, really well protected there. But let me just go back. This is one of the reasons why a femur fracture is really dangerous, especially in sports. And it happened to a Liverpool footballer called Gibril Cisse, and he fractured his femur, and it ruptured his femoral artery, because look how close it is. Yeah, so if you get the bone break here, it's sharp, then it will cut the femoral artery, and you'll just bleed into the leg. So what you need to do is stop the blood supply up here where the femoral artery emerges underneath the inguinal ligament. So if you do any kind of medical trauma courses, that kind of thing for sports especially, then you'll learn about that on those particular courses. Cool. So that was that bit. And then we've got, so these are the circumflex arteries here that supply all around the head and the neck of the femur. So literally form like a loop all the way around. So the femoral, which we've just seen, the deep femoral where it splits, and then off of that, then the medial circumflex and lateral circumflex that go around. We've got a similar kind of pattern in the shoulder as well. So we've got circumflex arteries in the shoulder too. Cool. Right. It's got the last couple of videos. So this is the supply, hopefully, to the glutes. Yeah. So this is now looking at the internal iliac. There we go. So there's the common iliac artery. So that's it coming down as the descending aorta. There it splits. So you can see the split just there. That's the common iliac. Okay. And then there's the external iliac. There's the internal iliac. Yeah. So just to give you a bit of an orientation again. And then as we come down here, you can see these coming off of that internal iliac. There we go. So there's your superior gluteal artery, and there's the inferior gluteal artery. Yeah, so these are the supply for obviously the glutes and around the hip rotators. Here we go. So if we take off glute max, there we go. There's your piriformis, there's glute med, and then you'll be able to see the arteries coming through. There we go. So sciatic nerve, which what we're just looking at, and then there's the arteries just there. Look at them emerging. So that's how they innervate the muscles. So they literally just latch on and then supply them with blood. Okay. And then the last one that we're going to have a look at, some of the veins. Just show you this one. That will take us perfectly up to time then. Okay, so let me just pause that. That is what it looks like when you just take off the skin. Okay, so underneath the skin is a layer of fat, so the subcutaneous fat. Okay, and that's what it looks like. Your ASIS is just there, so literally they've just, it's a really good dissection because it's hard to do. With it just taken off the skin and left everything else. Look at all the fatty tissue there, and then there's the skin again. So it's like a millimeter. This is the long saphenous vein. Okay, this one's often used for grafts. And there it's going up into there. So that this is up into your femoral triangle. So there's your inguinal ligament. long saphenous vein just here. So this is drainage from the leg. Yeah. So all of the deoxygenated blood coming back from the leg and from the regions around it as well. You can see where it's receiving blood from all those areas as well. So through the lymph nodes, there it is there. This is really good actually. Inguinal ligament just there. So what it's doing is it's going through that femoral, there's your femoral triangle there. Perfect. Okay, so we've got nerve, artery, vein, and then if you remember the image, then your Y fronts. So we've got navy, nerve, artery, vein, and then your Y fronts. And that's them side by side. Okay, so you can see everything there in that femoral triangle. So that one's receiving deoxygenated blood, that one's sending oxygenated, and that one's your nerve supply. And there it goes there, underneath the inguinal ligament. So you've got a weak point here around that region, which is where herniations will, inguinal herniations will occur. And look at it coming up now into the abdomen area. So there's your external iliac vein, exactly the same name as the arteries. And then they then come up and then join into the vena cava. There's your psoas. So all of these should be familiar now. Internal iliac vein, so as well as the internal iliac artery, we've got a vein bringing deoxygenated blood back as well. Yeah, common iliac, and then there's your vena cava. So that will be going directly back to the right atrium in the heart. Right. Cool. Done. Sorry, it's a bit of a long one today. Let's pop that back. Hip and pelvis, done. Get rid of that as well. So took a few weeks that I think that's about the 7th or 8th episode around the hip and the pelvis. So as you can see, we go into quite a lot of detail, but if this is one of the first ones that you've done, then don't start here. Basically, I know it's a wrong time to say it right at the end, but go back to the first video on the hip and the pelvis and then build it up gradually, and we'll do that now for the next bit. So in the next session, I'll probably just do a pelvic floor one because we've done all the bony anatomy for that region anyway. And then we'll move up into the sacrum and the lumbar spine. Okay, so we'll go around that area there. But hopefully that's been useful. And yeah, it is also a bit of a brain mess, this one. Might be one that you want to watch over again. And because we're not on next week, perfect opportunity. So keep it in your diary, 10 o'clock Monday, and just rewatch this one instead. Thank you for your questions. If you've got any other questions throughout the week, just pop them in our Facebook group. Otherwise, I will see you in 2 weeks' time. See you then.